next one, Dr. Anu Sharma. Dr. Anu Sharma would be speaking about retinal sensitivity evaluation after chemotherapy and radiotherapy in retinoblastoma treatment.
Good morning, everyone. The topic of the presentation is the retinal sensitivity evaluation after chemotherapy and radiotherapy in retinoblastoma treatment. There are no financial disclosures and no conflict of interests. As we know, retinoblastoma is the most common neoplasm of the pediatric cancer, comprising of around 3%, wherein 80% are treatable. In high-income countries, more than 95% has a cure rate. The treatment includes conventional chemotherapy and various targeted therapies with the modern treatments. But the concern is the ocular toxicity, which impacts the retinal structure and the function. So there is always a need to evaluate the functional outcomes, not just tumor control. Apart from the life salvage and the globe salvage, the quality of vision is the most important thing which has to be addressed in survivors. So we conducted a study on retinal sensitivity, which is a functional indicator of the visual potential. The aim of the study, the primary objective and the aim is to evaluate the effect of the chemotherapy and the radiotherapy in retinoblastoma patients in terms of retinal sensitivity. And the secondary objective is the other variables which we obtained with the microperimeter to assess the fixation parameters in the extramacular regressed retinoblastoma. The evaluation tools used for the microperimeter, which we used was the scanning ophthalmoscope microperimeter, MAIA, and we also used Optos retinal ultra-wide field camera, which complemented the microperimeter to identify the peripheral tumors. So these are the maps we obtained, the retinal imaging we did. The study was conducted at Dr. RP Center between January 25 to June 25. It was a prospective comparative and observational study. So we included 14 patients with more than 14 years of age with visual acuity better than 618, so they could perform the test. And we also included 20 age-matched healthy controls. The macular sensitivity was measured using center view MAIA with a 37 stimulus grid. It covered 10 degrees of field. So we mainly used retinoblastoma survivors with history of more than 1 year of any treatment. And we excluded the macular lesion because it is difficult to perform the investigation. And we also excluded the active tumors. So 60% of the participants in the control group were males and 40% were female. As we already have come to know that there is a slight male preponderance. So 72% in the subjects were male and 28% were female. Mean age was 16 years, and in the RB survivors, mean age was 17 years, so statistically significant. The vision was better than 6/18. In the control group, the mainly vision was 6/6. So the key parameters of the microperimetry were retinal sensitivity, macular integrity index, and fixation parameters were P1 and P2. So I'll explain one by one. Retinal sensitivity is the average threshold across the tested points. The normal is 26 to 30 decibels, which is reduced in various inherited retinal dystrophies, ARMD, CSR, and glaucoma. So as in our study, we also saw that retinal sensitivity was reduced in the subjects. It was 26.6 compared to the normal control, which is around 30. Macular integrity index is another parameter which is a proprietary value of the equipment. It's a global index and is expressed as probability score from 0 to 100. So depending on the severity of the disease, the number shows the higher values indicate the higher disease severity compared to the lower values where the disease is less. So here, as we see in the disease group, the MIA index is 77, which is higher in the subjects compared to 54.4 in the controls. Fixation variables are the measure of fixation stability. It shows that how the patients are fixing with the macula. It is expressed in the P1 and P2 values, which are the percentage. In controls, it was P1 value was 95% compared to 71% in subjects. So P1 is actually the percentage of fixation points within 2 degrees of the diameter circle, which is positioned at macula. So as we see, even the fixation is affected in the diseased group, which is 71, P1 is 71 in the diseased group and P2 is 86, compared to around more than 90% in controls. So as we've seen, even if the disease is extramacular, it does affect the macular fixation. And this is clinical significant also. So these are the maps of the macular as well as extramacular retinoblastoma groups. The perimetry was done in both the eyes, and as shown in the maps, the one with the macular retinoblastoma has a central scar, so the macular sensitivity is almost 0 to 10. And whereas in the extramacular, although the retinal sensitivity is preserved, but it is less than normal value. So fixation location and fixation type is another parameter which is shown by the microperimetry. There is no such study conducted, but there is one case report published by Johnson KP where they did perform microperimetry in the macular retinoblastoma to show the preferred retinal locus. So to summarize, we want to tell that microperimeter can be used as an additional tool for the functional assessment because it picks subtle functional deficits in structurally normal appearing areas which we see on clinical pictures and OCTs. Reduction in retinal sensitivity is a noteworthy side effect, and assessment is essential in diseases treatment monitoring. Thank you.
A very informative presentation. Thank you.
What was the power of the study which you calculated for this?
The power was more than 90%.
Okay.